Hello everyone. Today we will be discussing the final part of endometriosis, that is the clinical features and the management. In the last lecture I discussed about understanding the disease. It was all about pathology, pathogenesis and how it goes, right? So now today we will be discussing how the patient will present and how will we manage the patient according to the patient tailored management. Clinical features. As I told in my earlier lectures also, whenever we are describing in a theory paper or in a practical exam or in our clinical approach, we always go with the history of the patient. We start eliciting the history and then form a diagnosis in our mind. So the age, first of all you will ask the age of the patient. Patient is generally between 30 and 45 years of age, definitely, because it is the time where the chances of encountering the endometriosis is the maximum. And now it is mostly the nulliparous women or who have 1 or 2 children. That means they have regularly bled. It is like for the 9 months the amenorrhea, the timings of amenorrhea is very less. So in modern times where the marriage is delayed and the conception is delayed, so the prevalence of endometriosis is increasing. There is often a family history of endometriosis. We cannot say definitely that it is something which is familial, but yes, you will find a history of endometriosis in most of the cases. Now what are the symptoms? Classical symptoms of endometriosis are, it's a triad, D, D, I, dysmenorrhea, infertility, dyspareunia. Classical triad, dysmenorrhea, infertility and dyspareunia. If we are describing endometriosis, these 3 symptoms have to be there, rest all are secondary. So in about 70% of cases, that is too much, too high an incidence. 70% of cases the presenting complaint is dysmenorrhea, that is very painful bleeding. This is a progressively increasing secondary dysmenorrhea. When we will be talking about dysmenorrhea, we will read what is primary, what is secondary. So earlier these patients were not having dysmenorrhea, but they developed dysmenorrhea with increasing age and it is progressively increasing. With years it will keep on increasing. The pain starts, classical, okay, the pain starts a few days prior to the menstruation, gets worsened during the menstruation and takes time even after the cessation of the period for the relief. So it is a co-menstrual dysmenorrhea. So what do you understand by co-menstrual dysmenorrhea? During eliciting your history, you will find the patient will say that the pain starts before the periods, whole throughout the periods, and even after the cessation, after a long time it will get relieved. So most of the time during the monthly cycle, the patient is in pain. Next is infertility. 40 to 60% of the cases. So highest incidences of dysmenorrhea, second number comes infertility. Endometriosis is found in 30 to 45% of infertile women, whereas in about 40 to 50% of the patients of endometriosis, they suffer from infertility. This line is important to understand, that whenever you see cases of infertility, in that cohort, if you will study the incidence of endometriosis, then it is 30 to 45%. But when you will study a cohort of patients with already diagnosed endometriosis, then in those cases, in about 50% cases, you will find infertility. What are the causes? We have already seen in our last lecture that the tubal patency is always present in cases of endometriosis. Then why infertility? It could be because of ovarian dysfunction, because of tubal dysfunction, because of uterine causes and others. What do you mean by ovarian dysfunction? It could be endocrinopathies, defective folliculogenesis, anovulation, there is inflammation of the ovary or the luteal phase defect, reduced ovarian reserve, definitely if there is some endometriomas, chocolate cyst. So because of the collection, the active portion of the ovary which is producing follicles, it decreases. So reduced ovarian reserve. It is associated with hyperprolactinemia, oocyte maturation defect and luteolysis due to the presence of prostaglandins PGF2 alpha. There are so many causes which can cause infertility. We don't know. A mixture of all these factors cause infertility, but yes, in cases of endometriosis, you will find infertility. So it could be because of endometriosis, this endocrinopathies, anovulation, luteolysis, Altered tubal motility. Patency may be there, but motility is altered. Pelvic adhesions. This is the uterus, probably the tube is adherent over here. So it is patent, but the direction changes, so the ovarian relationship is changed. It is not able to pick up the ovum. Distortion of the normal tube and ovarian relationship, impaired pickup, right? So it could be either ovarian or tubal, or if you come over here, uterine causes, impaired fertilization, impaired implantation, early miscarriages, abnormal endometrial receptivity, dyspareunia causing poor coital function, abnormal peritoneal fluid, which we have already studied, that there are changes in interleukins and prostaglandins in the peritoneal fluid which causes implantation failure, abnormal systemic immune response to the pregnancy, and increased sperm phagocytosis. We may not remember all of these things, but just to tell you that at every level, at the level of the ovary there is a problem, at the level of the tube there is a problem, at the level of the endometrium, at the level of the sperm, increased phagocytosis. So we don't know which factor is working in which patient, but yes, these patients may land up in infertility. Now comes dyspareunia, the third one, important thing, 20 to 40%. Dyspareunia means painful sexual intercourse. So the dyspareunia is usually deep. Deep means in the posterior fornix. It may be due to the stretching of the structures of the pouch of Douglas. Definitely this is the posterior surface of the uterus, and the uterosacrals are over here. So if there are some implants over here or anywhere around, it will cause pain. So stretching of the structures of the pouch of Douglas or direct contact tenderness. As such, it is mostly found in the endometriosis of the rectovaginal septum or POD, and with a fixed retroverted uterus. What do we understand by that? If you think about it logically, if the implants of endometriosis are on the posterior surface between the uterosacral ligaments and in your POD, the uterus will go back and the rectum, vagina and the posterior surface will come, make adhesions, and they will be fixed retroverted uterus. So in such cases, coitus is definitely painful. So I finish off with dysmenorrhea, dyspareunia and infertility. Now other which can be co-associated, but these are secondary, like abnormal uterine bleeding, which is present in 15 to 20% of the cases, and mainly heavy bleeding. Menorrhagia is the main abnormality because of the inflammation of the ovary and anovulation. If you remember that much, that is sufficient. Because of the presence of endometriomas or due to the surface deposits on ovary, there is inflammation, anovulation and prolonged and heavy bleeding during menses. Chronic pelvic pain, very, very important. As we were discussing, wherever there are endometriotic implants, it will cause inflammation of the local area, then necrosis, then inflammation, then necrosis, and it is a continuously progressing disease. So it will lead to chronic pelvic pain. The pain varies from small pelvic discomfort to lower abdominal pain or backache. Backache is very, very important. The causes of the pain is multifactorial. What all factors? Definitely peritoneal inflammation because of the endometriosis, increased prostaglandins and cytokines, which we have been reading since last lecture. Tissue necrosis at the same point of endometriotic spots, adhesion formation, nerve irritation due to deep penetration. In cases of DIE, deep infiltrating endometriosis, probably the nerve is also involved and the patient is having severe pain. Release of local inflammatory mediators and endometrioma formations. Whatever the presentation during laparoscopy, which I discussed in my last class, what all you can see, the AFS classification. Endometriosis is a disease where you cannot say a simple peritoneal defect may cause lots of pain to the patient, or a highly adherent uterus may not cause pain to the patient. So it is multifactorial, and it is very important to know the extent of the problem to the patient so you can decide what treatment to plan for the same. Now abdominal pain. It was chronic pelvic pain, now abdominal pain. There may be variable degrees of abdominal pain around the time of periods, or sometimes it may be because of the rupture of the chocolate cyst. Patient may present first time with abdominal pain only, and then you find out that it is endometriosis. So your main symptoms: dysmenorrhea, infertility, dyspareunia, abnormal uterine bleeding, chronic pelvic pain and abdominal pain. Others are regarding how the endometriotic spots are there and which organ is involved. There may be urinary frequency, dysuria, hydronephrosis, hematuria if the bladder is involved, or because of the adhesion there is problem, the ureter is involved, then there could be hydronephrosis also. If sigmoid colon and rectum are involved, the involvement of rectum is very important. In the side section, if you see, this is the uterus and this is the rectum, and there are endometriotic spots over here. If the patch goes deep inside, so there is definitely problem in defecation. The patient will give you a typical complaint of painful defecation, dyschezia, sometimes diarrhea, sometimes constipation, rectal bleeding, or even melena, blood in the stools during the time of periods. Patient may also present with symptoms of irritable bowel syndrome. So history taking is very important to just make a picture that what part of the body is involved and up to what extent. So depending on the organ involved, there could be various symptoms which patient can complain of. Chronic fatigue, definitely there is chronic inflammation inside the body. Perimenstrual symptoms like bowel, bladder symptoms, they may complain there is diarrhea, there is constipation around the time of the periods. Hemoptysis very rarely if the lungs are involved, or catamenial chest pain if the lungs are involved and during periods there will be bleeding from that endometriotic spot, so the patient will complain of catamenial. What do you understand by catamenial? Anything, any symptom which is present only during the time of periods. Now coming to the surgical scars, as I discussed, endometriosis can be present at surgical scars, mainly at the scars of episiotomy, C-section or hysterectomies. So it will be cyclical pain and bleeding from those sites, or bloody pleural fluid tap can be obtained in cases of pleural endometriosis, right? So depending on the site involved, other symptoms may also evolve. Now I finish off with symptoms, that is what you elicit in history. Now I come to signs. Signs, that means what you see as a doctor. Abdominal examination, you will perform abdominal examination. Definitely in general examination the patient may look pale if she is anemic, or there may be no finding in the general examination. In abdominal examination generally does not reveal any abnormality, does not. Generally in more than 90% of the cases per abdomen examination is normal. In very rare cases you may palpate a mass. If there is a huge chocolate cyst which can be palpated per abdominally, then only you will be able to palpate. So this is the abdomen, this is the umbilicus, pubic symphysis. So if there is a huge chocolate cyst, you may be able to palpate that mass. So enlarged chocolate cyst or tubo-ovarian mass due to endometriotic adhesion. Generally the mass is very tender to touch and the mobility is restricted. In cases of simple benign tumors, it is highly mobile, the ovarian masses are highly mobile. But if it is endometriosis, just keep it in and endometriosis means necrosis, adhesion, necrosis, adhesion. So if it is adhesion, it will be of restricted mobility and painful. Now pelvic examination is very important in cases of endometriosis. In per speculum examination you will generally not find anything. If there is some deep nodule in the POD, you may find a bluish hue, but it is very rare. Per vaginal examination, that is the bimanual examination, in that some of the positive findings which you find are pelvic tenderness. Patient generally does not allow pelvic examination because it is highly painful. She is suffering from dyspareunia deep. Whenever you go deep for your bimanual examination, there is pelvic tenderness, nodules in the pouch of Douglas, nodular uterosacral ligaments can be felt, a fixed retroverted uterus which I discussed during dyspareunia is also felt. Unilateral or bilateral adnexal masses, if there is chocolate cyst, you can feel that. And speculum examination may reveal bluish spot or may not reveal. Sometimes we have to do rectal examination or rectovaginal examination if the patient is complaining of tenderness posteriorly or there are rectal complaints, so you may find rectal nodules also. So just make a picture of the patient in your mind and then go with history, symptoms and signs. With this I finish off with examination and then I shift to the part of investigations. Investigations. It is such an enigmatic disease that you cannot say that the patient is having endometriosis till you see it from your eyes. So laparoscopy is the gold standard. Before laparoscopy, just to form a tentative diagnosis, you can go for serum markers, but they are not very helpful. The most important of all is CA125. CA125 is not specific for endometriosis, it is more specific for epithelial origin ovarian cancers. But yes, it is moderately elevated in cases of endometriosis, that too severe endometriosis. So we cannot diagnose any patient as having endometriosis on this CA125, but it is helpful to assess the therapeutic response. If you are trying to treat the patient and then you want to monitor that whether those deposits are decreasing or not, then you can have a serial monitoring from CA125. Others are MCP1 or monocyte chemotactic protein, glycodelin, which is a placental protein 14, interleukin 1 and interferon gamma. These are only for theoretical purpose, that you should know that yes, these are all markers which may be raised. But in all clinical practice scenarios, it is not useful. We are generally using CA125, that is only to monitor, not for diagnosis. Next comes imaging. In all gynecology cases, we first start off with ultrasonography. Transvaginal scan can detect ovarian endometriomas, definitely, right? In ovary, you will find homogeneous formation of endometriomas. TVS and endorectal sonographies are found better. TVS means transvaginal. You can go transabdominal from the abdomen of the patient. Transvaginal, the probe will be inside the vagina. Transrectal, the probe will be inside the rectum of the patient. So anything which goes close to those deposits, that means transvaginal or transrectal, are found better to find out rectosigmoid endometriosis, especially for DIEs, deep infiltrating endometriosis. Generally, if there is ovarian endometrioma, yes, you can pick up with sonography very well, either in transabdominal or transvaginal. But if the rectosigmoid junction is involved, it's better to go either from transvaginal route or from the transrectal route. But ultrasonography may miss out many deposits which we are not able to see, either they are small or they are at places where we cannot reach. MRI is the best imaging tool in cases of endometriosis with a sensitivity and specificity of 91 to 95%. In their T1 and T2 weighted images, you can actually find out deposits and the depth of infiltration of those deposits. If MRI is not available, you can go for CT scan also. CT scan is better than sonography, but lesser as compared to MRI. Now, depending on the patient's complaint, if the patient is complaining of dyschezia, blood in the stools, then you can go for colonoscopy, rectosigmoidoscopy. If there is cases of burning micturition, cyclical hematuria, you find that you want to study the bladder, then you can go for cystoscopy. The best way to diagnose endometriosis is just see the deposits from your own eyes. So you will have to put a scope either in the colon or in the urinary bladder or in the abdomen itself. So laparoscopy is the gold standard for the diagnosis of endometriosis. This is an ultrasound image of ovarian endometrioma. You can find that this is the right ovary of the patient. It is globularly enlarged with homogeneously appearing fluid filling the thing. If it would have been a hypoechoic, only black thing visible inside, it would be a simple cyst. But no, it is having a ground glass appearance with homogeneity all over. So it is blood, chocolate colored blood. So it is ovarian endometrioma, how it looks in a sonography. Now laparoscopy. Laparoscopy, that is putting a laparoscope inside the abdomen of the patient, inside the peritoneal cavity of the patient. It is the gold standard. Why? Because you can see where are the deposits, how do they look, what are the appearances in laparoscopy. I have already discussed in my last class. Now, what other benefits of laparoscopy? We can assess the lesion with the site, size and extent. I hope you remember in my last class I talked about AFS. American Fertility Society staging. It all depends on the laparoscopy findings. At the same time, biopsy can be taken. At the same time, staging can be done. At the same time, extent of adhesions can be seen and recorded for the patient. And opportunity to do the surgery at the same time. In most of the cases, what we do, we suspect endometriosis from other tests, from the history of the patient, our examination, and then we suggest that we will go for a laparoscopy. If during the laparoscopy we find that there are endometriotic spots, we will excise it at the same time. So it is diagnostic as well as therapeutic at the same time. Biopsy confirmation of the excised lesion is ideal, but negative histology does not exclude it. If you find in biopsy there are no evidence of endometriosis, but you cannot exclude the diagnosis if you have seen it from your own eyes. Now, how to plan a management for endometriosis? This is very typical, because it all depends on the age of the patient. What does the patient want? Whether she wants a treatment of infertility, whether she wants relief from the pain, what she wants. Because if you do a surgery or give some medicines, it may recur, because it is a progressing disease. The recurrence rate is very high, because it is hormone dependent, estrogen dependent. The moment normal menses start, the chances of recurrence of the disease is always there. So how do you manage, and what are the options that you will be offering to your patient? Now, our objectives of the treatment. Why do we start the treatment? It all depends on the patient. She wants relief of pain, she wants to improve fertility, she wants to prevent disease progression and improve the quality of life of the patient. Depending on what is our prior objective, we will go accordingly. Now, what are the options that are available? In some cases, we can go for expectant management. That is, if she is complaining of pain, we can give painkillers at that time and nothing else. We can give a prolonged medical treatment. We can go for surgical treatment or a combined medical and surgical treatment, depending on the choice and need of the patient. Now, what happens if pain is the main complaint or if infertility is the main complaint? So, if pain is the main complaint, it depends on the score of the pain scale, that how much pain the patient is suffering, whether the quality of life is so disturbed that she is not able to perform her normal activities, or she is having pain but it is tolerable. If she is having a tolerable pain, that is a minimal pain, then we will go for expectant management. We will not do anything, because we don't know which disease will progress, which will not progress. So till the patient is doing well on herself, we will leave her like that. But if she is complaining of mild pain which needs some treatment, we can offer painkillers, non-steroidal anti-inflammatory drugs. Simple painkillers, simple paracetamol, mefenamic acid, or a combination of both can help. COCs, that is combined oral contraceptive pills. A continuous course of COCs has helped. In my first slide, in the last lecture, I have told that this is a disease of controversy. If she has a cyclical regular menses, then the disease increases. But if we give the hormones regularly and there is a period of amenorrhea, the disease regresses. So we can give either combined oral contraceptive pills or continuous progesterones or GnRH agonist. These all medicines will create a scenario in which there will be no periods, so the disease will go into remission. Now, it was about minimal pain to mild pain. Now, if the patient is having moderate to severe pain which is not at all tolerable on these medication also, then we will go for laparoscopy. As I was talking about, laparoscopy gave us the opportunity for diagnosis as well as staging and the therapeutic at the same time. So the treatment will go on accordingly. We can go for laparoscopic ablation or the excision of the lesion or the adhesiolysis in the same sitting, whatever is the cause. If there are some lesions, there are some powder burns, or there are some adhesions or endometriomas, we can remove that specific endometriotic spot and the patient is relieved of the pain. This was all about if the pain was the main complaint and we wanted to manage the situation. See, endometriosis is a disease which can be managed, it cannot be treated forever. If infertility is the main thing, then go for ovulation induction plus IUI. This is an empirical therapy. Before going for surgery, you should try ovulation induction plus IUI for a few cycles and see whether the patient is responding for that or not. If not, then straight away shift to laparoscopy to find the actual cause of infertility and go on treating by adhesiolysis or ablation or whatever is possible at that time. Now, this we have already done for a patient of infertility as well as for a patient of pain. If the patient was having infertility after doing adhesiolysis and after removing the primary spot of endometriosis, we again go for controlled ovarian stimulation. That means ovulation induction, and then we can go for IUI, intrauterine insemination, or IVF-ET, that is in vitro fertilization with embryo transfer, or in general language, test tube baby. We can tell the patient that we have done the surgery, we have done the controlled ovarian stimulation, but if still you are not able to conceive because the infertility is multifactorial and we cannot treat each and everything, so we can directly go for IUI or IVF-ET. But if the pain was the main complaint, now what do? We have done the surgery, but we know it is a continuously progressing disease. Primarily we have removed the disease, but the chances of recurrence are there. So we will have to go for a continuous medical treatment to keep the disease in a stage of remission. COCs, GnRH agonist, progestins, Dinogest, which is again a type of progesterone, and Danazol. This is all what we can use. We will be studying about these drugs in some other lecture where I will be discussing only the drugs. These are the options which are available for the treatment of endometriosis. Even after it, if there is recurrence of symptoms, you have done everything, but the disease has come back. So, definitive treatment. This was not definitive treatment. We will trying palliative treatment so that the patient is maintaining the menstrual function as well as her normal life. But if there is recurrence of symptoms, go for definitive treatment. If the patient has a completed family, then hysterectomy plus bilateral salpingo-oophorectomy is the treatment of choice, because you remove the main cause, you remove estrogen from the body, ovaries as well as the uterus. Otherwise, if there is a midline lesion which is causing severe pain to the patient, then pre-sacral neurectomy can also be done for the relief of the pain. Now, in which cases what all will be done, I will be discussing in detail. Expectant management means observation only, right? Medical therapy, as I have told, we have hormone, we have NSAIDs, painkillers and other options. Surgery can be conservative or definitive. Conservative means adhesiolysis, removal of the implants, and definitive means hysterectomy plus BSO. And a combined therapy, that you go for a surgical therapy and then continue for a medical therapy. Now, how do we decide which treatment to be given to which patient? Depending on the age of the patient. Young patient, go for a conservative treatment. Patient with higher age group, increased pain, completed family, you can go for a definitive treatment. Location of the disease. If the location is bladder, patient is having complaint of hematuria, go for excision of that thing. Size and extent of the lesion, desire for fertility, how much the symptoms are severe, and what was the result of the previous therapy. If you have already done everything of the conservative therapy, then definitely definitive therapy is the only treatment of choice. So it is very, very important to go 1, 2, 3, 4, 5, 6. Just look at these 6 points and decide that which patient has to undergo what treatment. You have to tailor the treatment to each patient. Now, how will you decide when will you go for expectant management? If the patient is having minimal endometriosis with no other positive finding, she is unmarried, she is a young married woman who is ready to start family as early as possible, or a patient who is approaching menopause. That means the extremes of the reproductive age group, either very young patient or very old patient who is approaching menopause. So our idea of treatment of endometriosis is achieving menopause anyhow, medically, surgically or naturally. We want to remove estrogen from the body. Now, what all medicines are available for the medical treatment? I am giving you just the list. I will be discussing it later on in a separate lecture. How does these drugs work? So, a combined estrogen progesterone pill or COCs, combined oral pills. You have to give it daily for a period of 6 to 12 months, and it will create a state of pseudo pregnancy. That means the patient is not bleeding continuously for 6 to 12 months, and it is a well tolerated drug in the point of view from the side effects. So, you can start with COCs in young patients. If the patient is not able to tolerate, or the second line drug is progesterones. Progesterones only because it does not contain estrogen. We have option semi-synthetic one, medroxyprogesterone acetate, dydrogesterone, norethistron, Dynogest. Dynogest is a relatively new compound, and it is right now the drug of choice to be used in cases of endometriosis. Given is the dosage schedule, given is the duration, and generally till norethistron every drug is creating a state of pseudo pregnancies, and all of them are well tolerated, right? Even Dynogest is also creating a state of pseudo pregnancy. Now comes, this was all oral preparations. If you want to go for IM preparations, which we generally don't give in young patients, especially who want to conceive, DMPA, depot medroxyprogesterone acetate. It is highly easily available in India in every places, in small PHCs, CHCs also, because it has been used as a contraceptive. 150 milligram given every 3 months, it also creates a pseudo pregnancy like state. LNG IUD. LNG IUD means levonorgestrel containing intrauterine device, sometimes also known as Mirena. It is very helpful in cases of endometriosis of patients who don't want to conceive. So, it will give you contraception as well as it will release hormones regularly, and it will decrease the dysmenorrhea, it will decrease the menorrhagia, and it is helpful a lot. And if it suits the patient, then it is there for 5 years. So, it is also a well tolerated thing. Then coming to danazol. Danazol is less tolerated, it has got androgenic side effects, so nowadays we don't use. But danazol, gestrinones, they cause pseudo menopause like situation. If we generally don't prefer danazol or gestrinone, we directly go for GnRH analogs, that is leuprolide, triptorelin, goserelin. What do GnRH analogs do? They form a medical oophorectomy like situation, like they work at the pituitary level, right? Down regulation occurs, and there is like total loss of gonadotrophins from the body and medical oophorectomy, and they are well tolerated, but they have their own side effects like loss of bone. Initially there is a flare up symptom, and then the symptoms will subside, and we cannot use it for long time because of the presence of osteopenia. Now, other medications which can be used, but they are not that popular as those were which we were discussing. Progesterone antagonists like mifepristone in a dose of 50 milligram orally per day can also help. Selective progesterone receptor modulators like esoprisinil can also help, but it can cause endometrial hyperplasia. See, our idea is to decrease the spots, to make an environment where there is no hormones, so there are no proliferative changes. GnRH antagonists are also well tolerated and used. Oral are elagolics. So, the initial, where there is the initial flare up symptoms with GnRH analog, it is not there in case of GnRH antagonist. Aromatase inhibitors like anastrozole or letrozole can also be used. Simvastatin, rosiglitazone, they also reduce. So, these are just for your knowledge that these medicines are also available, but first line treatment was that which I read in the tabulated form. Important to know, following medical suppression of the disease or conservative surgery, residual endometriotic lesions may regenerate once the ovarian function is re-established. You should tell this to your patient that yes, I am giving you the medicine, but it may regenerate, it may recur. Overall recurrence is 40% after 5 years, which is too high. So, medical treatment and conservative surgeries are just to pass the time so that the patient approaches menopause on her own. Now surgical management of endometriosis. When will you shift to surgical management of endometriosis? There is endometriosis with severe symptoms and not giving response to hormonal therapy. When there is deep infiltrating endometriosis and you want to correct the pelvic anatomy, which is not possible from medical management. And severe endometriosis with pelvic adhesive disease. Whenever there are high levels of adhesions where the whole anatomy is distorted and the patient is having deep infiltrating endometriosis, then surgical excision is the only treatment of choice. Again, there is conservative surgery and definitive surgery. Conservative surgery, we generally go with a laparoscopic method where we can cauterize the lesion, we can go for laser vaporization, laparoscopic uterosacral nerve ablation, adhesiolysis, excision, drainage of endometrioma, aspiration. How do you manage endometrioma, right? These are the depending. See, if you will see my last lecture, I have given you a variety of presentation of endometriosis in laparoscopy. So depending on the thing which is occurring, you have to decide there and then proceed with the surgery. If it is an endometriotic spot, you can either excise, go for cauterization or fulguration. But it is endometrioma. What is endometrioma? Chocolate cyst or the presence of endometriosis inside the ovary. You can go for either aspiration and irrigation, or cyst wall vaporization, or cystectomy in cases where the size was more than 4 centimeter, then it is always easy to peel off. This is the endometriomas in the ovary. You leave the normal ovarian tissue behind and just peel off this cyst wall. Take out every material out and the wall also, so that the recurrence is very less. So endometriomas can be aspirated, can be vaporized, but cystectomy is the treatment of choice in cases of endometriomas. Definitive surgeries, the approach can be either from laparoscopy or laparotomy depending on the situation of the patient. Hysterectomy with bilateral salpingo-oophorectomy is the final definitive treatment of choice. Dissection of bowel or ureter may be needed for complete removal of endometriosis. What does that mean? Even if you are removing the uterus and ovaries, but there were large endometriotic spots, huge adhesions where the ureter was involved, the rectum was involved, you cannot leave those spots inside. You have to take it out. So partial resection of bowel or ureter may also be needed. So it is a multidisciplinary approach surgery. Now endometriosis at special site. Special site means away from abdomen, that is scar endometriosis, mainly episiotomy, umbilicus, hysterectomy, hysterotomy, caesarean. These scars, nowadays we are finding more and more patients of scar site endometriosis. Hormone therapy is not effective in cases of scar site endometriosis and excision is the treatment of choice. So don't try any medical management in cases of scar site endometriosis. With this I finish off. I tried to compile all of the things, but it is a vast topic and I hope you people get benefit from this topic.